Today, Wednesday.
Yep.
Oh, right. Good morning. It's Wednesday, July 30th, 2025. And today we're just going to go through understanding your Medicare, which is going to be your care in the future at some point, whether you're 65 or not yet. Right now, that's the system we have in place. Medicare is for people over 65 for health insurance taken care of partially by the US government, the money you've been contributing. Some people under 65 get it due to disability, but we're not going to really discuss that today. This is really just for the people that have reached the grand old age of 65 or older and have decided to give up employer benefits, and they're going to use Medicare, for which they've been contributing um, their working career. So let's jump right in, talk about some of the basics for Medicare. So, when are you eligible? Well, you're eligible when you turn 65, but you can actually have an enrollment period that starts 3 months before that and extends 3 months after that. So, that creates a 7 month window, actually. So, in this example, if you're born in April, you get January, February, March, you can enroll in your Medicare. And if you're going to add a supplement or an advantage plan, something like that, we're not going to talk too much about those today, just the Medicare part, but you can enroll before April and it will start April 1st. If you don't enroll by April, you can enroll the 3 months afterward. So May, June, July. Now, it won't be retroactive to April 1st. It'll just start the first of the following month. So if you sign up in May, it's going to start June 1st and so forth. So that's the basic enrollment, your initial enrollment period. However, the question I get most often is, how do I do it? Well, if you're already going to start your Social Security benefits, it's easy. Social Security is going to enroll you in Medicare. They're going to not only enroll you, but they're going to start deducting your Part B premium from your retirement benefits. So it's easy. If you're not enrolling in your Social Security retirement benefits and you just want to enroll in Medicare, you go on ssa.gov, find apply for Medicare, and just follow along. It's not very difficult. Um, they prefer if you do it on the web. You can call, but the way things are lately, I would try to do it online first. Here's the question I get asked a lot. What if I want to continue working? Do I have to enroll in Medicare? Well, and the answer, like so many answers with Medicare, is actually maybe, but it's not that hard. If you work for a small employer, 20 or less, so 19 or less, actually, you need to go ahead and enroll in Medicare because Medicare is going to be your primary insurance. And if you don't have it, then you don't have it. And that's not going to work. If you work for an employer with 20 or more or a larger employer, then you have the option. You can keep your employer benefits and delay your Medicare, or you can drop your benefits and take Medicare. The way we do that, we help people. We just get a summary of their benefits and what they cost, compare them to what Medicare would cost and the different options available to them. They decide which one's going to work better for them. One of the most important things to remember, though, is if you have a spouse or children tied to your employer benefits and you drop those benefits because Medicare is better for you, what's going to happen to their coverage? So sometimes there's alternatives. Sometimes those are affordable. Sometimes they're not. There's, several things to consider. So leaving a spouse without benefits is pretty much unacceptable. So you want to make sure you have another alternative set up before you do it, or know if it's just a bad idea and you're going to keep working for a while. Maybe just delay your Medicare for a while. You can always start it later. As long as your employer had 20 or more employees, your insurance is going to be called creditable, which basically means good enough for Medicare. If you're smaller than 20, they don't like it. They want you to join Medicare. So, what if I want to continue working? You can delay it if you work for a big employer. Join it whenever you decide to quit working. All right, different parts. This is the confusing part. of Medicare for a lot of people. Parts A, Parts B, Part C, Part D. So we're going to go through each one just a little bit. This is just going to be a brief introduction. So start at the beginning. Part A. What does Part A mean? Well, that's your hospital benefit. So this means if you're going into the hospital or you're going to be an inpatient in a facility. So hospital is usually the most common facility. The second most common is what we call skilled nursing facility. Medicare helps pay for a lot of that. But on this little slide, you can see the 2025 cost. These numbers change every year. The mechanics stay the same, just the actual numbers change. So this year, the first day you go in the hospital, it's $1,676 is the Part A deductible. But that lasts for days 1 through 60. If you're in from 61 to 90 days, then you start having a copayment of $419 a day. 91 days on, it's $838 per day, up to a maximum of 150 days. Now, those last 60 days are what they call reserve days, and you only get to use those once. So if you're really concerned about that, talk to a broker, let them explain that in greater detail. You can stay in the hospital for 90 days. Those days don't run out. Get out. After a while, you can go back for another 90 days. That's the shorthand version. If you need to stay in on one time past 90 days, now you're going to start using those reserve days, and you get to use each one of those only one time. So you're not limited to 150 days total. It's just 90 days per benefit period. Then you start using up your reserve days, and those last days are the ones that are limited. All right, if you go in skilled nursing, so maybe you have a surgery in the hospital, you're not quite ready to go home, or you live alone, you can't get around by yourself yet, but there's nothing they can do for you in the hospital. A lot of people go to a skilled nursing home, skilled nursing care, skilled nursing facility, or what a lot of us call rehab. So we're going back, getting some therapy for a week or 10 days, something like that. Well, Part A does a pretty good job. It pays the first 20 days of that. So you get in there, days 1 through 20, there's zero copay. Days 21 through 100, it goes up to $209.50 per day. And then after that, you're on the hook for 100% of whatever that facility charges. So very rarely do people stay in that long. Most people don't even stay in the 20 days statistically, but everybody's different. So it's good to know, it's good to start out with, but it can get expensive on you pretty quick. Home health. It can be covered by Part A or Part B. What I tell a lot of my clients is it doesn't really matter if Part A is covering it, Part B is covering it. It depends on how it's prescribed and things like that. Just that one of them is covering it and helping you pay for it. Okay. So if you're coming out of the hospital and it's getting prescribed by them, it's probably going to be Part A. Get a couple of days a week, 2 to 3, and they should take care of that. Also, that's your facility. Similar to hospice. Hospice, if you go into a hospice facility, could have a small charge, about 5% of the cost. Most people honestly do hospice at home nowadays. That's your facility, so they don't charge you, and hospice comes free. In my personal opinion, the 3 times I've been through hospice with loved ones, it's been about the best terrible thing you could have, or the most terrible best thing you could have. However you want to look at it, those people are pretty awesome, the people that can do that. So make sure you get some good references if you need that service in your area, and you'll be really glad that you did. Don't go without it. It's an awesome thing. All right, so Part A, that covers your room and board, things that you get to use in the hospital, but not always people that touch you like doctors. All right, how does that get paid? Well, Part B is what we call medical. Everything's got 3 names: medical, physical, outpatient. It's another way to think of it. So you go to the doctor. Part B, doctor does surgery on you. Well, part of that's Part A, part of that's Part B. The doctor part's probably going to be Part B. MRIs, emergency rooms, ambulances, all those things that you do as an outpatient, those are going to be covered by Part B. Part B is the part of your Medicare that does have a premium, unlike Part A. If you worked 40 quarters, about 10 years, your Part A is paid for. It's not free, it's just paid for because they've been taking that out of your paychecks. Part B, however, has a premium once you start it. For 2025, it's $185 a month for the base price. That number will change in 2026. And that number can be higher even this year based on the earnings that you have from 2 years ago. If you're a high earner, you actually get what's called an income related monthly adjustment amount, or IRMA in shorthand. And that gives you the opportunity to pay more for your Part B. So congratulations on being a hard worker. You get to pay a little bit extra, and there's different thresholds for that. A local agent that you work with can easily show you those thresholds and help you determine whether you're going to pay extra or not. In addition to your premium, Part B has a deductible. Remember, Part A had a deductible $1,676. Part B is actually one of the most reasonable things in Medicare. This year, it's $257 for the whole year, your annual Part B. That's really good. After you reach your $257 annual deductible, then Medicare becomes an 80-20 plan, where Medicare pays 80% of your Part B charges and leaves you 20%. That's pretty good. The downside is there's no cap on that 20%. So if you hardly ever go to the doctor and you spend, your $257 a year, well, that's all you spent. You spend another $100 or get charged another $100, you only got to pay $20. That's not bad. You get chemotherapy or something else that costs $100,000, now you're on the hook for $20,000. So, 80-20, not terrible, but there's no cap on that 20, like employer plans that have a max out of pocket. There's no max out of pocket on Medicare. So that's one of the gaps that we'll help people fill once they enroll in Medicare. All right, so A, inpatient, facility, hospital. B, outpatient, medical, and physician. Those are what we call traditional Medicare. Those two actually come and are managed by the federal government. All right. The next thing we hear about so much is Part D, and we often think this is provided by the federal government. Part D is not provided by the federal government. It's provided by a private insurance company. However, the federal government requires it in the way that it can. Now, they can't require you to buy things, but they can penalize you for not having it once you were eligible. So what that means is, once you're eligible for Medicare, if you don't have creditable drug coverage and you don't get Part D, if you try to get it later, 2 years, 5 years, 10 years, you'll have to pay a penalty for not having had it all those years you were eligible. What they're trying to do is get more people contributing to the pool when they're healthy, so that offsets the cost for everybody else. If you delay, only get it once you need to start it, then they're going to penalize you. Those penalties are based off how long you were eligible and didn't have it, and those penalties last your entire lifetime. Once you start it, they'll never go away. So if you never get Part D, well, then you'll be okay. Most people end up having to get it. So we always suggest just go ahead and get it. Even if you don't take any drugs, find the absolute cheapest plan in your area for that year and just keep an eye on it. And then if you do get new prescriptions, go through that with your broker and they'll help find the appropriate plan. Just don't go without it, because once you get those penalties, they'll never go off. Now, they do give you an opportunity. If you're a veteran, they'll count the veteran or the VA as creditable drug insurance, drug coverage. So veterans oftentimes don't have to get Part D. They can use the VA for their drugs, not their medical. They still have to have the Part B in order to avoid the Part B premium or penalty. But Part D, they are able to go without that. And in fact, there's even some special advantage plans built kind of for veterans. Talk to your local broker and they can help you figure those out. All right, so how does my drug plan work? Well, if you have a standalone drug plan, it's probably going to have a premium, so a monthly cost to have it, plus the cost of your drugs. This can get really confusing because there is a drug deductible that the insurance companies can charge. However, this year in 2025, a lot of them didn't charge it. on the lower price drugs, what we call lower tiers, tier 1 and tier 2, and we'll talk about the tiers in just a second. So even though the government says they can charge a $590 deductible, depending on the plan, they may or may not charge it for those less expensive drugs. And so you pay the premium and then the cost of the drug. Well, a lot of those tier 1 drugs don't even have a cost, or they're very low, just a few dollars. So it's not too bad. So you pay for your premium, don't have to pay the deductible, then you pay the cost of your drugs. Almost all of them start charging the deductible on tier 3, and then 3, 4, and 5, anything above a 3. A few don't on the 3. It's just specific to your area and the plans available in your area. But basically, they'll all start charging a deductible on tier 3, and that's when drugs really start adding up, 3, 4s, and 5s. Those are the brand names. What I tell a lot of my clients is the shortcut to know is if they advertise it on TV, it's probably a 3 or above, because they don't advertise 1s and 2s. They're just not worth it. All right. 2025 was a big year for the drug plans. They put a cap on it. They always had a cap, but it's pretty high, so it didn't feel like a huge savings for a lot of people. 2025, they dropped that to $2,000 max out of pocket, meaning if you ever have to pay up to $2,000 of your own money for your copays for drugs, then you're done for the rest of that calendar year. There's a lot of figuring in math that goes into it. We're not going to go into that today. Just know that actually a lot of those times you don't even pay the whole $2,000, because depending on your plan, some of what the insurance company pays towards it is on your behalf. That goes towards that $2,000. So you may even pay a little bit less than the $2,000, but you won't pay any more. So that's good. After that, you're $0 for your drugs for the rest of that calendar year. It does reset in January, on January 1st of the next year, and you'll have another $2,000 max out of pocket. Actually, in 2026, it'll be $2,100. It's going up just a little bit. Still a lot of protection for drug coverage. So make sure you understand it. Make sure you have somebody run your plan with you, or you understand how to run your drugs through Medicare.gov and you understand how your plan works. It can be very confusing, but it can also be explained to you pretty well. All right, here's the tiers. Tiers 1, 2, 3, 4, 5. The lower the number, typically the less expensive the drug. Tier 1s are a lot of the generic drugs that a lot of us take every day, once or twice a day. Blood pressure, statins, thyroid, just a whole bunch of stuff. They're things that are common to you. I won't go through the list of medications right now, but if you take them, they're the things you get every month. They're usually zero or just a little bit of money. Tier 2s, again, pretty common, not as common as 1s, but cost a little bit more. Tier 3, when they start getting expensive, you see them on TV. Those are where they have a brand name. That's when you start to notice it. Really, 4s and 5s are even more expensive. 5s tend to be specialty drugs. If you're on a 5, you know it. Typically, they're for very specific things that not a lot of people take them. Now, when I say that, a large percentage of people is what I mean. There's still a lot of people that take them, but the percentage, most of us are on 1s and 2s. If you have any questions about it, you can always check the formulary with your drug plan. Every plan has a formulary, which is the list of drugs that that plan covers. They don't have to cover every drug. They just have to cover a drug for every condition that Medicare has defined. In every category, they have to have at least one drug. Different carriers can classify their drugs as a different tier. You don't see that a whole lot, but they can if they want, because the drug companies, insurance companies can basically do whatever they want. They'll have rules and they'll usually follow them for at least a year, but a lot of them, they don't even have to do that. They can change in the middle of the year. So it pays to have a local broker that you can talk to and who'll check on those things in your area, because honestly, you have to stay in a plan. If you have a contract, you can't change, but the insurance companies can. A lot of people don't realize that. It's just one of those things about it. We got to stay on it, and you got to have somebody who can help be an advocate for you. All right. How else can they control their costs? Well, they can do a couple of different things. They can use what we call step therapy. The drug companies, if there are multiple drugs to treat the same condition, they can ask that the doctor prescribe you the cheapest one first. If you haven't used it, the doctor can't give them a valid reason why you can't use that one, say a generic over a brand, then they're just going to require that you try the generic first or the cheapest one. If it works, they're going to have you stay on that one. If the doctor can document that it doesn't work, or you have a reaction to it, or it's not effective, then they can ask to use a different one, and they can step up. That's step therapy. They can limit the quantity. A lot of us get drugs for 90 days at a time. We get 3 months at a time, and that's okay for a lot of drugs. But some things they just won't give it. They're too expensive. And so they'll only do 30 days. Or some aren't meant for ongoing, they're just meant for a short time. A lot of times pain relievers might fall into that after a surgery or something like that. So they'll only give you whatever the number is, 15 pills or 16 pills or enough for 4 weeks or something like that. But only once every other day. So whatever it shakes out to, they can limit the quantity. Pre-authorization, doctor can write it, they see it, and they're like, no, we need more documentation on why you need this drug. They'll go back to the doctor and make them complete some more information, and they'll need to get some more authorization before you can do it, or you need to get the authorization, and the pharmacy needs to get the authorization before they can actually fill it. I don't want to say it doesn't happen a lot. Percentage-wise, it still happens a lot, but percentage-wise, and it's usually the same drugs over and over. Um, not not your typical things that you just need, like I said, for statins or blood pressure, or simple things like that. It's going to be more expensive things. It's just a cost control measure. And then formulary exception, that's kind of what I was talking about before. They all have a list of drugs for each plan. That's the drugs that plan will cover and at what cost. And say you do take a drug, but remember, they don't have to cover every drug. And your drug's not in the formulary. 9 out of 10 are, but one isn't. They have the other drug that covers your condition. Well, if the doctor can document that that drug will not work for you or cannot work for you, they can request the formulary exception where they will cover the other drug. It's up to the insurance company to approve it. Your doctor is going to document it, and your doctor is actually going to ask for the formulary exception. They don't have to do it. If they do it, they don't have to cover it at the same exact cost as the other one. So are there options? Yes. Are you in control of the options? Not so much. But work with a broker, work with your provider, and more things can happen. You just got to keep trying. All right. So we talk about the gaps in Medicare a lot. You'll hear everybody talk about this. This are those deductibles, your Part A, your Part B deductibles, your Part D deductible when you have to pay it on your drugs, the copays, especially for Part A, and the 20% on Part B, and the no cap on your 20%. Those are the main gaps. There's a few other gaps because Medicare doesn't cover everything. It doesn't cover like dental insurance. It doesn't cover your glasses or your hearing aids. So people want to fill those gaps. So how do they do that? Well, they usually have two choices. They can add a Medicare supplement or a Medigap. Those are the same thing. You'll hear both words. Supplement and Medigap are the same thing. What is that? Well, that's another insurance policy offered by a private insurance company. It has a monthly premium, okay? And a local broker can quote it for your area. All the carriers are listed for them. They can see all the different prices. So it's not just a one or done. They have a lot of different options. The nice thing about these are there's no networks. So any doctor that accepts Medicare will accept any supplement. And the most popular one out there right now, or the one with the most benefit, is what we call Plan G. And Plan G, you pay the premium each month in addition to your Part B 185. And then you pay your $257 deductible, And then after that, it covers the 20% on your Part B, and it covers all of your Part A deductibles and copays. So basically, you pay your premium, your $257, then all your medical bills, Medicare billable medical bills are covered. So Medicare doesn't cover your drugs, so your supplement doesn't cover your drugs. Medicare doesn't cover your dental, so supplement doesn't cover your dental. If Medicare doesn't cover it, the supplement doesn't cover it. If Medicare does cover it, the supplement does cover it. So they're very easy to work with. They're very popular. They do come with an extra cost. So Plan N is the other one that's real popular. Almost the same. It just adds a copay when you go see the doctor of up to $20. If you go in the emergency room, of up to $50, that then gets waived if you get admitted. Those two copays, they usually get you $30 off compared to Plan G each month. So you do a little bit of math and you can figure, is it worth doing that one, or do I really need the G? If you're not much of a user, Plan N may just be perfect for you and save you $350 a year, whatever the exact dollar is, based on your area, based on your zip code and your gender. All right, the other gap you have to fill is your Part D, and that's where we talked about getting a separate plan from a private insurance company. This plan is most likely going to have a premium. That premium is going to be based on all the different drugs you take. Okay, so your Medicare broker can run your drugs and tell you what all your drugs will cost on all the plans at each pharmacy in your zip code each month. It's pretty cool. Now, just understand that a lot of drug plans, they don't really compensate brokers very well. So brokers who are doing it for you are usually doing it in order to just be of great service to you with your other Medicare needs and things like that. So just keep it in mind. Most of them still do it for you. We do it all the time for people. Um, it's a big part of their business because it's a big part of helping people. It is not a huge revenue source for them. So just keep that in mind with how demanding you are on your broker for your drug coverage, because drug companies are really, really tight with that kind of stuff. They're not very helpful with a lot of people. Every year, you'll have a few different rules. 2025 had the biggest changes, the $2,000 max out of pocket, and then the deductible that a lot of them waive on those low tiers. So it's important to look into your drug plan. There's a lot of them available, and you want to make sure all your drugs are covered to the best of their ability, because not every plan covers every drug the same. All right, so one way to fill the gaps: Medicare supplement and a Medigap paired up with a standalone Part D plan. The other thing you'll see a lot, you probably get a lot of mail for it if you're 65 or over, or you see it on TV, is what we call Medicare Advantage plan. The confusing part about this is your Part C. Part C is not offered by the government. It's not part of traditional Medicare. It's not required like Part A, B, and D. Part C is an optional plan. It's the identical thing as an Advantage plan. Those are the same thing. So how does it work? Well, it depends on your market. Some markets don't have them, or they have very few. We're in a big market. I'm actually in the Dallas-Fort Worth market, so we have a lot of them, and most of them don't have any premium at all. They're $0 plans. Now, don't confuse the $0 plan with free. In Medicare, nothing's really free. It just has a $0 premium. Well, then what do I do, Mark? Well, after that, you have set copays for all the services that you receive. So if you go into the hospital, they're going to waive your deductible, and you just have a flat copay per day, somewhere $300 to $400 in there per day for either 5 or 6 days. Depends on the plan. They all vary a little bit, so nobody can tell you every plan in a quick video, but they can look them up in your area for you. So you go in the hospital, there's copay. You go see a specialist, cardiologist, orthopedic surgeon, there's a fixed copay to go see them. You have an outpatient surgery at an ambulatory surgical center, cataract surgery in and out the same day, fixed copay. Have your shoulder scoped in and out, same price as the cataract surgery, honestly, because it's going to be a set copay. Have an MRI, fixed price. Take an ambulance ride, fixed price. Emergency room, fixed price. So you get it. Those things are all limited. The other nice gap that it fills is that no max out of pocket. Your Advantage plans all have a max out of pocket. Again, it varies on plan. Our market is pretty competitive, so ours is just around the $4,000 mark on HMOs. Other parts of the country, it can be much higher. So it just depends on where you live. You have to check out your local plans. They do, now this is the thing you'll see them advertise a lot, are the extra benefits. And they'll tell you dental, vision, hearing, transportation, gym. A lot of them will even say healthy foods, all kinds of stuff. Every plan is different. So just because you see it on a commercial, is there a plan that has all that stuff? Maybe. Do they all have some of that stuff? Most likely. And they combine it all into one commercial. So you're like, oh, I want the plan with everything that doesn't cost anything and I'll feel great all the time. That's not really the plan that they're going to talk to you about. They're going to tell you a more realistic plan once they get you to call or once they get you to respond to an ad. That's just the way it is. Just know when you call, if you call them or if you respond to an ad on the internet, that the plan they advertise is the most idealized plan that they can say that's not untrue, but it doesn't mean that it's a plan everybody can get, but everybody can call and ask about it. And that's really what they're going for. All right. So here's the other thing you may see. I don't like the advertising that much. I love the plans. I just don't like the advertising. They'll say vision, 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 vision. If you have eye problems, cataracts, glaucoma, macular degeneration, diabetic retinopathy, none of that falls under your vision insurance. That's all under your medical insurance. If you have Part B and you have a Medicare supplement, that's all covered. When they're talking vision and Advantage plans, your checkup and your prescription glasses or contacts. That's what that means, not actual eye disease. All right. So a lot of people get confused by that. The dental is what it is. Medicare is terrible on dental. Everybody knows it. Everybody will tell you that. The Advantage plans, some of them will give you an allowance towards dental. Make sure you understand them. Some are better than others. They all vary in how much of an allowance they'll give you, and they'll all vary in what they actually cover within that allowance. And they'll have a network that you have to stay in on most of them. A few of them don't. Most of them do. And that takes me to one of the most important things about Advantage plans is they all work on a network, either an HMO network or a PPO network. HMO network means there's one network of doctors and providers you have to stay in for the insurance company to pay anything. If you go outside of that network, the insurance company won't pay other than the emergency room and your ambulance, because you can never predict those. And they're not going to leave anybody without that kind of protection. So if you need an ambulance, call an ambulance. If you need to go to the emergency, go to the emergency room. You'll still be in network. You'll be okay. The PPO, on the other hand, gives you the opportunity to go outside of that network. If the other doctors will accept the plan, terrific. You can go. Your company will pay some of it. They're not going to pay as much as they pay it in the HMO, but they're not going to leave you hanging with 100%. How much will they pay? Depends on the plan. They may pay 50%. They may pay a fixed rate. It just depends on each individual plan. That's why people shop plans and go through it with their broker. If they stay in the network, but they're on a PPO, they're most likely still going to pay more than if they were in the network on an HMO, because they're paying a premium for the opportunity to go out of network. So remember that. So if you're just going to work really, really hard to stay in the network on your PPO and you live in a big area with big networks, you may just want to stay in the HMO. But that's a preference. A lot of people don't even want to mess with the HMO. They usually require referrals, although some carriers are doing away with that requirement. Be sure to ask. But the PPO will cost more money. All those copays will be higher and your max out of pocket will be higher. An example, here in the Dallas-Fort Worth area, if the HMOs have a max out of pocket of about $4,000, the in-network on a PPO is $6,700, $7,000, somewhere in there. Out-of-network starts at $10,000 and goes up from there. They'll keep track of where you received your services, and they'll keep those separate. Your out of or your out of network and your in network max out of pockets. So that's how we fill the gaps. You can get standalone dental, fill that gap. You can get standalone, what we call vision insurance, but it's for the glasses and your regular checkup. You can get insurance for that. Um, there's just lots of other stuff in the market. So really what you want to focus on first, the advice I give everybody that I work with, is focus on the health first. Your health, your doctors, your budget, and then extras. They advertise the extras first. You should be shopping those last, in my opinion. You should be more focused on your providers that you want to have, when and where you can receive services, and then if you can afford those services, and then if there's a gym membership or some healthy foods included. I know a lot of people rely on those, but if you can't get in a skilled nursing facility because you have a plan that's low rated, and people have known that's a problem, well, it's not going to matter, because you're going to be a very unhappy person because you shopped extras before you shopped for care. And but that's an opinion. I'll share opinions with you. I'll try to keep them general. Oh, let me show you that one thing. So Advantage plans are rated on 5-star level, 5 being the highest, 1 being the lowest. 5-star is pretty good. If you have 5-star plans in your area, they're getting pretty good reviews. There's not a whole lot of them. I think this year in Dallas I think we didn't even have one. We might have had one for a while. Some years we have them, some years we don't. They get rated every year. I don't recommend anything below a 3 to any of my clients. In fact, if they're below a 3 for a certain amount of time, CMS tells them they need to make serious changes or just leave the market. But so you don't see them very often. Usually you'll see a 3 or above. 4s are probably the most common, but they will even do half stars sometimes. So you just got to keep an eye on them. But again, not every plan is right or wrong for other people. If your providers are in it and the cost is good and you've been on it, and for whatever reason they're getting 3.5 stars, not that fourth one, but you never had a problem, don't worry about it. Your experience counts just as much as what the paper says sometimes, if you have experience. If you don't, then I'd look for higher rated stars. All right. When do a lot of people get hammered with Advantage plan information? Well, during the annual enrollment period. So what is the annual enrollment period? This is the time in the fall, October 15th through December 7th, when people who are on existing plans get to enroll in a new plan if they choose to. And why would they choose to? Well, the plans, Advantage plans, only last from January 1st to December 31st each year. So every January 1st, a new plan is going to start. Now, some years they don't change the plan, it just rolls over. If it was good for you, you were happy, they're not changing, you don't have to do anything. You just let it roll over. Other times your plan may change dramatically. It may even leave the area. We're seeing that a little bit more in these last couple of years. There's always shifts within the Medicare industry. They may just drop a plan. Well, now you have to pick a new plan, right? Or they may raise your copays and lower some benefits, or they may just do away with some benefits, and you do want to shop those. If your doctors take multiple carriers, maybe you do want to shop a little extras. As long as you know you can get your care when and where you need it, then the extras are important, and they do make a difference. Just keep in mind, you're not required to switch unless your plan is going away. You will get a letter sometime between August and the end of September, and it's called your annual notice of change. And that letter will put your current plan next to how that same plan will be in the next year. So this year it'll be for 2026. If it's still good for you, just let it roll over. It'll happen automatically. You don't have to shop them. You don't have to call your broker. You don't have to do anything if you don't want to. If you want to, then call somebody and talk to them. They'll be happy to talk to you. Just don't think you have to change because it's that time of year. That time of year is the opportunity to change if you need or want to. All right. So if you are new to Medicare, there's a couple of do's and don'ts we share with people, and these are pretty general, um, not totally absolutes. The best thing that I recommend you do is find a local broker or a person that you can meet at least once. You can work over the phone or Zoom or on the internet, stuff like that. A lot of this stuff we can do electronically, but you need to be able to meet them at least once, I think, or talk to them and get to know a little bit about their company, their reputation, people in your area. Do they know your area at all? I feel those things are important. So, uh, my little bit of first bit of advice is if you don't like getting all the calls or you don't like getting all the advertisements, don't respond to them. Enough people don't respond, they'll stop doing it. But if people respond, they're going to keep doing it. So that's the best thing. Anything unsolicited is not looking out for you. They're looking out for themselves. If they're calling you and telling you you need to change, that is a red flag. So if you're enrolling for the first time, don't take big retirement account distributions the 2 years before you enroll in Medicare without understanding how that affects your IRMA, that income related monthly adjustment amount. If 1 year you take a big chunk out of your 401k before you retire something, it's going to get reported as earnings. You may have to pay more for your Medicare. I'm not saying don't do it. I'm saying make sure you understand how it will affect your Medicare. A broker can help you. If you have a financial person, they should be able to explain it to you, a CPA, if you have somebody help you with your taxes. Just make sure you understand it. Not telling anybody what to do with their money, just what you need to know about the effects of using your money. Don't delay enrolling in Part D or Part B if you don't have coverage, because if you get those penalties later on, they'll never go away. And they increase as the cost of Medicare increases, your penalties increase also because it's a percentage. Don't automatically assume that a well-known company that you've had while you worked or while you were under 65 is the same in the Medicare market as it is in the under 65 market. That's not true. Depends on your market, depends on a lot of different factors. There you go. Don't sign up from an unsolicited phone call. That's my opinion. A lot of people do it, obviously, because that's why they keep calling us. Don't sign up from an 800 number or from an ad on the internet. Everybody complains about them, but they wouldn't do it if it didn't work. So um, I recommend everybody use a local broker or a smaller national broker that can actually spend time with you, has customer service department, and that you've reached out to and you've been able to vet a little bit, either through other people that you know or just some type of information that they're able to provide to you. There you go. Do you use a local broker that offers several options? If you use an agent or you use somebody from a carrier, they can only show you the one carrier. Brokers can show you all the carriers in your area. And the nice part is, especially Advantage plans, all the commissions that are paid are regulated by CMS, so they're all exactly the same. So there's no financial incentive for a broker, an honest broker, to steer you towards a plan because they're going to get paid the same no matter which plan you go in. The best thing for them is to make you feel like you have the best plan for you. You're happy, you tell 10 friends, and a bunch of those friends come to that broker too. That's the real incentive, doing the right thing for you. You do not save money by doing it yourself. A lot of people think they're going to have to pay a broker or pay an agent. Nope, it's free to use our services, not just mine, but any broker out there. They're compensated by commissions through the insurance companies. So whether you sign up online yourself or you use a broker, you're not going to save one penny by doing it yourself, but you run the risk of getting into something you don't understand completely. So I advise against that. Make sure you know that the plan is suitable for you, not that it sounds good on TV. Make sure you understand it. And if you don't, ask for clarification. Anybody that really wants to put you in the best plan is willing to take the time to walk you through it, explain how it would work. Here's a scenario. If you had this situation or this situation, you need to pick up this drug this many times a year, whatever it is. Almost all that can be determined pretty quickly using the tools that we have available. If they're not willing to do that with you, I would move on. And then do know what Medicare does cover, doesn't cover. Do know what your Advantage plan covers, doesn't cover, and your supplement covers and doesn't cover. If you have any doubts, just ask, because we know what it will cover. And if we don't know, here's the other thing: any broker that's been doing this for a little while has all kinds of resources. So Medicare is pretty complicated along with Social Security, but we can find out a lot of stuff faster than you're going to find it out by calling uh, CMS, 800 Medicare, Social Security Administration. Those can just be a nightmare, but any broker that's been doing this for a little while can usually get any answer you need. If they don't know it right away, they can find out pretty quick and get right back to you. So that's another part of the customer service that I think is important. People should look out for. So that is the down and dirty. My name is Mark Bilgier. I own Bilgier Insurance. Again, I'm in the Dallas-Fort Worth area primarily. I'm in about 13 other states. So if you want to reach out to us, if I'm not in your state, I do know people in every state, I believe, that I could refer you to, which we do that a lot. If we can't help people, we'll just get them with somebody we know that'll take care of them. There's enough of us around to help one another out. It's pretty easy to do that and get you connected with somebody that can help you. There's our local phone number, BillGearInsurance.com. We're on Facebook and wherever you're seeing this. And so I appreciate you spending the time with us today. Please feel free to email us, info@BillGearInsurance, if you have any questions. If you're in the Dallas-Fort Worth area, look us up on Agent Hub, Medicare Agent Hub. We're pretty easy to find. So I appreciate it. Have a wonderful Wednesday.